So, good morning everyone, and thank you Dr. Kamaljeet sir for inviting me for this presentation. So, I shall be speaking on how you can manage a case of glaucoma with cataract. We all know we have, of course, options of doing a trabeculectomy first and then going for cataract surgery, but there would be cases where you have very high pressures with advanced cupping and you want to go ahead and do both the surgeries combined. So just to show a couple of cases how we manage it, this technique is the flying incision technique which Dr. Malik only came up with the idea, and this is the kind of incision I'm going to use. So what I do is, after making a conjunctival peritomy, you have seen I've left a frill of conjunctiva close to the limbus, and this is the flying eagle shaped incision which we publish also. And this incision, it has a square, you can see the center has a square, the rest of it is round shaped, and then of course the incision and the wound and the SICS is as you do regularly. So these I like to make side port also in all my incisions regularly now, and this helps in, of course, not only the capsular rhexis, but in I actually have started using a bimanual during washing in all my cases. So this is the keratome entry, and after that the nucleus is brought out as in any SICS. So the advantage of this square shaped flap here is that if you suture both the ends, it prevents the wound drag post-operatively, maintains the chamber and the flap, and after that this is just to wash the chamber, because sometimes if your chamber is becoming too shallow again and again, if in a case where you already have a compromised disc, you do not want the pressure to rise and fall again and again. You want a constant pressure, so you can just put a suture, complete your wash, and then place your IOL in the bag. And once this is done, I don't use any Kelly's sponge. I simply use a MVR blade, and MVR blade is used to make a sclerostomy, and this is a 1 hour scissors to just cut off the sclerostomy, and then of course this is the peripheral iridectomy being done. So it's a very simple technique. I put 2 sutures on both the ends. As I said, this not only prevents the chamber from being leaky post-operatively, it also prevents against the wound shift, so astigmatism is less. And after suturing the conjunctiva the way I've done, you have a very good bleb post-operatively. So this is a case where you already have a pre-existing bleb. So here in these cases you need to change your site of incision. So this you have to change to the temporal. You don't want to spoil your conjunctiva pre-existing. Since it was a very hard cataract and I did not want to go in for a phacoemulsification, so I decided to go in for a SICS. These patients where you already have a prior surgery, sometimes you have a lot of synechiae formation like in this patient, and the nucleus may be difficult to prolapse out of the bag. Then the next step is to take it out of the section. Now this AC maintainer, because the wound was leaky because due to the trabeculectomy bleb, the pressure was not building up, so I made use of a this irrigating wire vectors to prolapse the nucleus. This is a very interesting case with a pre-existing bleb with an absolutely flat chamber. This chamber is actually totally flat. So there was no working space, there was no way I could do an SICS. But if you see, when I pushed the dye, the bleb was functioning, yet the pressure was very high. So how to manage this patient? The patient had only PL, the PR was also inaccurate, so I had nothing to lose. So what I decided to do, I first made side ports to push the viscoelastic. Still the chamber did not form. Then I decided to go in and do a little bit of core vitrectomy. So this is a port 3, this is 4 millimeter pars plana infusion being placed. Little bit of vitrectomy was done, and because of this, the chamber, after this, the eye becomes soft, and I put in the viscoelastic, the chamber was formed slightly. Then I put in my vitreous sweep, and I created, released some of the synechiae, did my rhexis. You can still see the cornea is pretty hazy, chamber is still very shallow. Still there is no scope of doing a SICS. You can go for an ECC, but SICS no. So now I decided that I'll do a in the bag phaco. So this is a direct job being done in the bag, and the moral of the story is you need to know all surgeries to to handle all these kind of cases. So this is just because there is no space in the anterior chamber, so you have to do an in the back phacoemulsification, and that also a direct chop. You cannot go for a stop and chop. So after doing this, the chamber deepened a little more. Now you can see the things are a little better. And I implanted a IOL within the bag. Again, it was not with high pressure, such shallow chambers. If you open up and you try and put a bigger lens, there are chances of expulsive hemorrhage. So I didn't want to open the chamber further. And now you can see the chamber has formed. And these are the past planar infusions I've removed, done a vitrectomy, and actually this patient got a 6/12 vision after the surgery. So never give up. Keep trying whatever you can. Many patients with glaucoma, they may present with PR inaccurate. Classically in the books we have been told that if PR is inaccurate, you are not going to get vision. I've seen patients who actually present with PL negative, and we have been able to save those eyes. So never give up. That is my principle of going about. You can of course talk to the patient that nothing more is to be lost, but at least give one try. So this is how, why this patient had a a very good bleb, yet the chamber was flat, was possibly in the post-operative period, whoever had did the surgery never bothered to follow up the patient to ensure that the chamber was formed in the early post-op period. So possibly the peripheral anterior synecdoche had formed, and the patient developed this kind of a condition. So I think, thank you so much. I will be very happy to take any questions. Thank you.
But Professor Ruchi, you thought of not doing the iodectomies, PIs, 1 or 2, 3?
Sir, already the trabeculectomy was done and the PI was already there.
One PI.
So that's enough.
But you never thought of adding the iodectomies?
Sir, there was no need for that. The problem was that there were total posterior synecdoche all around. So probably the entire angle at the periphery was blocked because of the synecdoche formation. Otherwise, the fluid was functioning. You could see the dyes going through it even before I entered the chamber.
Very good and very difficult case, and we should appreciate